All right. Good morning, everyone, and thank you so much for joining us today at the Public Safety Solutions for Substance Use Disorder ECHO, brought to you by Center for Substance Use Training and Telementoring, CSTAT, at Beeville, Texas. My name is Shreya Prasanna, and I will be facilitating our discussion today. A few quick housekeeping before we begin. These sessions are enabled for live closed captioning. If you would like to view closed captioning for this session, please navigate the bottom of your Zoom window and select the Show Captions option. To help us with attendance, please enter your name, affiliation, and email into the chat. To access the chat feature, please click on the speech bubble icon on the navigation bar at the bottom of your window. And please note, we are recording these sessions for later distribution through the Beeville, Texas YouTube channel. Any information that you put in the chat will not appear on these recordings. We encourage everyone to join by video for the discussion portion in the latter half of the session. That said, regardless of how you've shown up today, we are just as happy that you're here to learn alongside us. Please stay muted unless you're speaking, and we do encourage you to speak. If you've joined by computer, your mute button is on the bottom left of your Zoom controls, or if you're on the phone, just press *6 to unmute. You can also use the reactions menu in the bottom right of your Zoom screen to raise your hand and indicate that you have a comment to share. And you can also use the chat to share your perspectives. There are a lot of us in this space, so please keep your comments brief to allow others the chance to share as well. And finally, please note that no protected health information is allowed in either the chat or our discussions, and that includes names, addresses, dates, pictures, or any information that can easily identify an individual. Towards the end of the session, the Beeville, Texas team will send out a link to an evaluation survey. Please fill it out for a few reasons. It gives us your feedback on how to improve and refine these sessions to address your priorities, and it allows you to access free continuing education credits. We are approved for CEs for paramedics and any public safety professionals with a behavioral health degree. All participants filling out the survey will be automatically entered into a raffle for a $30 Walmart gift card. Today's session will start with a presentation on the research and realities of drug market disruptions by Dr. Bradley Ray and Ashley Shukait. Following that, we will hear a case from Ashley. There are a lot of professions represented here today, a lot of experiences and perspectives. I encourage each of you to share that during a discussion so that we can all learn from each other in the space. And with that, we will do some introductions. Cynthia.
Good morning, everyone. Happy to be here today. My name is Cynthia Mendiola, and I am a retired federal probation officer. I also am a trainer and a coach for the area of core correctional interventions. And then I also work as a child and family protection specialist, care specialist. And I'm happy to be here and welcome to this session.
Thank you so much, Cynthia. Jeremiah.
Hi, everyone. Jeremiah Golka, Executive Director of the SHIELD Training Initiative. We do operate occupational safety and health trainings for law enforcement and criminal justice folks in their work responding to the overdose crisis. And yeah, I'm excited to be here today. Excited to hear Brad's presentation. Hey, Brad.
Thank you so much. Brad, Ray.
Hey, everybody, Brad Ray. I am a senior researcher at RTI International.
Thank you so much for joining us today. Ashley Shukait.
Hi, everyone. Ashley Shukait. I'm just really excited to hope this kind of changes discussions.
Thank you so much for joining us today. Andrea Hebler.
Hello, everyone. My name is Andrea Hebler, and I am a program coordinator here at CSTAT, UT Health San Antonio, and welcome, everybody.
Thank you so much. And with that, we will move on to our didactics. Dr. Ray, you can take it away whenever you're ready.
All right, thank you. So next slide, please. Next slide. Well, there's some disclosures. We have none to report. Next slide, please. There's our learning objectives. So we're going to describe how law enforcement drug seizure data were used to examine trends in overdose. We're going to explain the underlying mechanism of how drug market disruptions can increase overdose risk. And we're going to discuss some strategies that practitioners can use to prevent this or other negative effects of drug enforcement. Next slide, please. So by way of background, I'm trained as a sociologist. I got involved in this line of research a little over 20 years ago. Someone close to me overdosed from heroin, but was saved by naloxone. And this led me on a journey to learn more about naloxone, why everyone didn't have access to it. And I got to meet Dan Bigg, who is the executive director of Chicago Recovery Alliance and a true pioneer in naloxone distribution. Dan was my first ever community partner and my first ever research project that I'd ever worked on. I ended up leaving Chicago, getting a PhD at North Carolina State, and I had my first job at Indiana University in Indianapolis. I was there for several years, moved on to Wayne State, where I was in a social work department. That is where I met my co-presenter, Ashley Shukait. And I'm currently at RTI International, and I'm a full-time teleworker, so I live up in Duluth, Minnesota. Next slide, please. So as I said, my first ever research project back in 2002 was looking at overdose deaths. Dan Bigg at Chicago Recovery Alliance used to say, you know, if we don't know where people are dying, it's hard for us to prevent those overdose deaths. So as a master's degree student at DePaul University in Chicago, my job was to comb through death certificates, overdose death certificates, and input that information into a database. I went on to grad school, found myself in Indiana as a professor. And the very first contact I made in Indiana was the deputy coroner. And I said, I just did this awesome project in Chicago where I was collecting death certificates. We should start doing this in Indianapolis. So she and I started to collect data on overdose deaths in near real time. You can see this is a little bit lag now, but like much of the Midwest, fentanyl has been driving overdose deaths in Indianapolis and Indiana since the summer of 2014. Next slide, please. So prior to fentanyl hitting Indianapolis, I found myself as a professor in a criminal justice department, which was not my background, but I was able to meet the sheriff and I was able to meet the chief of police. And in 2013, the chief of police would convene these regular meetings and he would ask, what could law enforcement be doing to reduce overdose deaths? And so myself and the guy you can see on the right there in the gray, that's Dr. Dan O'Donnell. He's the director of EMS in Indianapolis. He and I developed the first training for law enforcement to administer naloxone in the state of Indiana. And it just rapidly expanded from one department to one agency to the entire state. And Dan and I published several studies on this that I could chat further about if folks are interested, but we just continued to collaborate on a number of different things. And it was around 2017 when Dan and his informatics specialist from EMS, we were meeting, we were brainstorming ideas, and they said to me, Brad, we've noticed that when police seize drugs, overdoses in that community increase. We actually have to purchase more naloxone because we know overdoses are going to increase after they bust up a house. And they described it very much as a community level effect, that if a house was disrupted, that there would be an increase in overdoses around that house. And I, at the time, found it to be one of the most important research questions that had ever been posed to me my entire life, still do. Next slide, please. So as I looked into the literature on it, there really wasn't much. There really wasn't much tying drug market disruptions to overdose. One of the items that I found that I continue to tell people about is this report from the DOJ. This report was over a decade before this phenomena occurred. So I'm sure many people here know sort of the first, second wave of the overdose epidemic. That first wave, when people could no longer obtain prescription drugs and moved over to illicitly manufactured heroin. A decade before that occurred, the DOJ was writing this report that said that that could happen, that if we were to cut off prescription supplies, that overdoses from heroin could increase. And I can talk a little bit if people are interested in the Q&A, and I really want to get to that. If they're interested, there are some programs that the feds have developed from that report. The other study that I found was a qualitative study out of the New England area where it had this quote that was almost verbatim to what Dan O'Donnell had said to me from an EMS person. Once there were drug interdiction events, they would see these localized spikes in overdose. Next slide, please. A couple of my colleagues at RTI, Dr. John Zibel, Dr. Ernie Aldridge, they published several studies looking at this from an aggregate level perspective. So that is, they'll look at, how much fentanyl was seized in August of 2014 and how many overdoses were fentanyl related the following month. So it's very aggregate over time statewide. But to me, it just didn't get to that very community level effect that Dan had described, Dan O'Donnell, that it happened in the community. So that's really what we wanted to focus on in this study. Next slide, please. So to conduct this research, which has since been referred to as the drug bust paradox, what we did is we obtained information from the police property seizure room, so the property room data that they had. So every single time police seize drugs, take drugs from somebody, they put it into the property room, they mark what they believe that drug to be and when and where it was seized. One of the major limitations of the study, I will tell you, is that none of the drugs went through confirmatory testing. That is, if police put it into the property room box and they called it cocaine, we treated it as though it was cocaine. We ended up getting 2 years of data, property room data, to conduct these analyses. Next slide, please. Our outcomes for, well, first off, you can see there what we did is we took the property room data and we broke it into opioid-related seizures. So this was heroin, fentanyl, prescription medications, and stimulant-related seizures, methamphetamine and cocaine. For our outcome, for our overdose events, we looked at fatal overdose events, when and where those fatalities occurred. And we had these 2 measures of non-fatal overdose events. I'm sure most people here know this, but not all overdose calls for service result in naloxone, but naloxone isn't always administered because of an overdose call for service. It can be other reasons why it's referred. So our non-fatal overdose measure, it's all overdose calls for service to EMS and all naloxone administrations. We could have looked at the ED data, but again, we wanted to look at this happening in the community, so this was the best source. And then we have that separate measure of just whether or not naloxone was administered. Next slide, please. So I did not run the analysis on this particular paper, but I've gotten pretty good at explaining it. You can imagine that if you were to take a concentric circle, our circles were 100 meters, 250 meters, and 500 meters. This was based on some prior work that we had done with call for service data in Indianapolis, why we came up with those ranges. But you can imagine any city, if you were to put a circle down like that, and you could count how many overdoses happened in that range. What we essentially did was we centered those circles around drug seizure events. So now we're asking, okay, here's where a drug was seized. How many overdoses occurred around that seizure? Next slide, please. And then we added a temporal component. So now we're asking, okay, around that seizure, how many overdose events occurred 7 days before and how many overdose events occurred 7 days afterwards? And you can see our space-time parameters get bigger. So we have 7 days at 100 meters, 14 days at 250 meters, and 21 days at 500 meters. And we're looking to see temporally after that drug seizure event, did overdose events increase? Next slide, please. This is not a very appealing slide unless you're into statistics. So let's just skip this one. We'll go to the next slide. And it's a visual representation of what's on that slide, just so you all know. What we ended up finding was that across all of our outcome measures, when opioids were seized, there was a significant increase in overdose events at all space-time parameters. You can see here, we did not find that same effect for stimulants. So when stimulants were seized, we did not see this same large increase in overdose events. The main finding, one of the main findings that we talk about from this study that's often cited, quoted, is that fatal overdoses more than doubled 7 days and 100 meters following a law enforcement opioid-related drug seizure event. Next slide, please. So it's been my goal to replicate this study since we completed it and improve on it. So one of the major ways that I wanted to improve on it was we don't, in this, our first methodology, it's just a pre-post test. We all know that drug seizures and overdoses are more likely to happen in some communities than others, and we weren't able to account for that in our first paper. So we've modified that. We now use what's called a complex contagion modeling approach so that we can look at those community level effects. We've replicated the Indiana analysis doing that, but we've also worked on replicating this in another city. And I really wanted to do it in a city that was much different than Indianapolis, where the drug policies were different, the drug landscape was different. And so we went with San Francisco. And this, the other papers are in print. You could read them now. This one is currently under review, but we find the very same findings, that where opioids are seized from in the city of San Francisco, and it's more immediate. We actually looked at 3 days in that one too. that there are these significant increases in overdose events around that. Next slide, please. So this is our hypothesized mechanism. This is what we think is going on. We didn't test all of this in our first study here, but it is our goal to continue teasing apart this hypothesized mechanism. So what we're suggesting is happening here is that if you're purchasing drugs from a known supplier, a known merchant, you have some sense of what you're going to get based on prior experience, based on how much you know that person. Once that person is arrested, if they're arrested or their supply is otherwise disrupted or seized, then individuals will go on to find another source. I think when I've been talking to law enforcement for a couple of years now about this analysis, and I think this is the one part where people, the misconceptions come into place. Law enforcement in any city in the United States, they know of very little of the illicit drug supply. The feds estimate around 5%. That means of where you're sitting right now, all of the illegal drugs that are in that community, police know of about 5% of those illegal drugs. It is easier to sell drugs and find drugs. They're cheaper than they've ever been in our society. And so people can go find another supplier. When they do find that other supplier, the amount of time that's passed before they find that new merchant, their tolerance could have decreased. So they might have to take less because of the time that's passed, but also when they purchase from that new person, they have no idea what they're about to get. They don't know if it's stronger or less potent or more potent. If it's cut with different things, they have no idea. And this inhibits their ability to properly dose themselves without knowing their tolerance. And this increases the risk of overdose. This is very similar to the mechanism that increases overdose when people leave jail as well, where there's this loss of tolerance, and if they're obtaining it from a new supply, they're not sure what's in there. So with that, I'm going to turn it over to my co-presenter, Ashley Shukait, and look forward to some questions.
Hi, everyone. I know you have access to the slides, so I'm going to just run through. This is totally not important. I'm a nerd. I'm a person in recovery, person who uses drugs, and a chronic pain patient. So I kind of fit in all these little boxes that oftentimes when our prescriptions are restricted, we end up having to use the illicit street supply. Next slide. And just to elaborate, when he discussed, Dan Big, this, when we talk about harm reduction, it was really rooted in queer, trans, Black, brown people who use drugs and sex work survival systems. This was way back in the 70s, 80s, when oftentimes people who use drugs were considered disposable, and I will argue that we still are. And we had to protect ourselves. Next slide. And so when we were talking about community caring, that starts with us. And a lot of times when individuals use drugs, we have these relationships that provide limited protections within this prohibition framework, right? And so we look at the socio-ecological models, we can see that disruptions can impact various factors. And it depends really on what your resources are, what your network is, and your access to those resources and information. And since harm reduction is rooted in community, often that we have this solid connection to our community members for this basic understanding of our local supply. And many of our merchants or people who sell drugs also, have this ability to be educated. Unfortunately, when there's a continuous microscope to criminalize people who sell drugs, often it is not the large level sellers, right? Like it's usually just friends selling to friends. Everything is you take what you can get, you don't throw a fit, and you try to make the best of it. So when they're selling, they may think they know what they have, but oftentimes they do not. And so with this hypothesis, a person is using what they believe to be true, and a person is selling what they believe to be true. And so when those police interactions seize their personal drugs or arrests, this impacts a very micro level of community members. Next slide. And so what does that look like when, something happens, when there's a drug bust? Generally, for harm reductionists, we're notified by people who use drugs, whether it could be our participant who was arrested. And it also could be like, hey, I can't get a hold of my plug or my supplier. And so when individuals are opioid dependent, they can start feeling very unwell very quickly. I know we talk about like the first wave of fentanyl towards, mid 20s. But often many of us were seeing this around 2005, 2007. And so there was these very distinct features as fentanyl has started taking over the supply. I am in Michigan and we've had fentanyl in our supply pretty consistently for the last 10 years. And so individuals do not have a choice to be dependent on it. And so for harm reductionists, we're quickly to spread the word. We check in with our public health officials that we work with for our syringe service programs. Our immediate concerns are withdrawal management and safety planning for individuals of like, okay, you're really sick. What are we going to do? Sometimes it's saying, hey, I know you talked about treatment. Do you want us to take you to treatment? Or sometimes it's, I know you're very sick. How can we connect you to other types of services so you're not feeling this and making riskier decisions? We instantly increase our naloxone distribution. And if we can, provide more drug checking supplies and services. Testing strips are great. However, they do not tell us the percentage. So people are still unaware of like what they're actually consuming. And we also provide overdose spotting in person or virtual access, which is what this pictures are Never Use Alone, Safe Spot, and then Brave technology. And so there's lots of ways. However, with stigma and criminalization, oftentimes these lines are not used or people are scared. And it's really reaching out of like what supply was impacted. In some states, supply is really marked by the bag. And so people can say like, hey, this bag with a Superman on it is gone. In Michigan, I've never seen a marked bag. And our supplies go by various, like just a few names. And so like we can't track down exactly what it is. Like everything's boy or dog food or dog chow. Like there's no rhyme or reason to what the supply is. And it makes it tremendously harder to track down. And so we hope that we build these connections with different types of services, but in the reality, it's protecting people who are really in desperate measures to not feel good. Next slide. And as I mentioned about the fentanyl supply, I'm sorry, but we have never had such an unregulated, inconsistent supply that varies across region, times, and communities. I cannot call the west side of the state to say, hey, what's going on? Because their supply is so different and these disruptions are ever changing. And it's this very much whack-a-mole case for us. Our powders look alike. Cross-contamination happens, especially under that microscope of criminalization. And generally, people have always used polysubstance. I know we think of like these waves of different types of substances impacting individuals, but truly most people have used various substances by choice. And so when individuals look at death certificates, it's such a limited scope of information. And so when we are presented with these disruptions, over the years, it's great. We're seeing more public health messaging, public safety messaging of like, hey, there's fentanyl in the supply, but it's not helpful because it's just very fear-based censoring and people are numb to it. If you say fentanyl's in the supply, they're like, yeah, okay, like that's been a thing. And now we have xylazine in our supply, medetomidine, and some other products. So it's kind of like, yeah, okay, we're not fearful about this. The same as COVID, right? Like everybody had these large messaging to the point where you became numb because you're like, I still have to function and go to work or go to the grocery store, right? And so how do we notify people? For myself and my colleagues and participants, we do it through art. It's one of the biggest things. Sometimes we'll send text messages very quickly when we first find out, but we have some wonderful artists who are people who use drugs, who are outreach workers, and they send out alerts. And so this is one of them that an artist named Andy drew for me when we were talking about like, what's your favorite animal? And I said tardigrades. And so they drew this, and like instantly it was such a big hit in the community of like, hey, let's have a discussion about harm reduction. I'm like, oh, did you know this was in the supply? Like what is going on? And like having individuals who are impacted most being at the center of the solutions, especially for messaging. And when we talk about these specific instances, does the messaging describe the substance of concern? Does it say what it actually looks like? Sometimes that is very, very telling for us to help distinguish what the supply concern is. And then so also it helps us with reversing overdoses, just like when xylazine came aboard, our overdose response has changed so much in the last few years to focus really on safety protocols and rescue breathing, as opposed to naloxone administration in rapid successions. And does these messaging, stigmatize people who use substances? People who use meth are very, very stigmatized. So when messaging comes across, it can be very brass, as the same for fentanyl users. Decade ago, people didn't want fentanyl. And we're at the point that people are dependent. So sometimes it's not a matter of wanting or not wanting, it's about what our bodies are used to. And then does it offer alternatives, right? We don't have a safe supply. Canada has one, barely functioning because of pushback and stigma. So all of these pieces kind of form together when harm reductionists are aware of the supply under such scrutiny and environments. Next slide. Okay. I ran through that quicker than I thought I would.
Ashley, did you want to go over those two intervention things?
I do. I
Yeah,
think
okay.
though on the agenda it said that there was like a 5-minute
Okay.
thank you introduction. I followed the agenda today.
Well, thank you so much, Dr. Gray and Ashley. This was a very, very interesting presentation, and I'm sure our learning community here will have some questions. So I'm opening up the floor for any questions or comments for today's presentation. I thought those diagrams especially were very powerful, which you showed where the drugs seizures were happening and the impact on the overdose deaths. I mean, I did not think about that association, so I thought that was very powerful.
Thanks. I'm glad to see everybody here agrees with the mechanism.
Jeremiah.
I've got a question. I remember at some point in a conversation, at some time in the past, where Brad, you mentioned that there's some federal recognition of this dynamic that has an actual like a practice thing where I don't remember who it came through, or if it's DEA or CDC or something will call for more local medications. And forgive me if you actually already mentioned this in
No, that was actually the slide that I buried on Ashley on accident. So yeah, so right now there's a program called the ORRP, the Opioid Rapid Response Program. It is run by the CDC. And if the law enforcement in your community are about to take out a prescriber, not just because of overprescribing, sometimes it's like a prescriber is also a sex offender, and they're going to arrest this prescriber, the main prescriber of buprenorphine in a community, for example, then the DEA coordinates with the ORRP to make sure that once they take that supplier out, that there's a backup. And they're working, and this is the most important point here, they're working on this before they take that supplier out. I've gone around the country, I've talked to law enforcement about this mechanism for years now, and that is the issue. Law enforcement will not share this information out to public health, to harm reductionists, to coordinate an effort. They're too worried about the nature of the information, that it could get out, that it could spoil an investigation. But truly, that is what we need to do. We need to have law enforcement recognize that when they do these disruptions, that there are increases in overdose. And then what can they do to mitigate them? And that is going to require, if they're going to continue to disrupt the drug supply, that is going to require pre-planning, not post-planning. I'll just mention one other thing there that I encourage law enforcement agencies to do. We also did a content analysis, hundreds and hundreds of news stories about drug seizures across the US. And you all have seen these stories. I mean, they're so formulaic, guns and drugs out on a table and everybody's, the thumbs up, we did a good job. And only 1 out of 250 stories that we analyzed from the news media, only one story told people where they could get treatment, where they could get harm reduction. So the simplest, lowest hanging fruit is that next time we want to toot our horns about disrupting the drug supply, we acknowledge the reality of that disruption. And we tell people that are reading that story, here's where you could go get help. And so we have I could send a link to it afterwards, but we actually encourage the Never Use Alone hotline and then local resources there as well.
Thank you. Were there any other questions or comments?
Yeah, actually, I had one other question, which was just the on the history of the that early paper on how cracking down on prescriptions could turn people to the street market. Did you see much? Had there been some life in that, and there's some citations of that going on, or like one of those kind of?
Yeah, the main
original?
citation I use is from somebody named Tammy Mark. And she did one of the first studies that I saw on it, where it was looking at people who were being prescribed out of an ED, I believe, and then showing how many of them ended up dying from heroin use. So that's the best paper I've seen on that transitional period.
There was a CDC acknowledgement as well several years ago about this was concerning. And I think we're trying to all throw red flags right now on the deprescribing of Adderall and other stimulants, because we are definitely seeing more individuals going to meth because they cannot get their medications. And if people don't know what they're buying, especially if they've never used illicit drugs, they don't, they may not know what meth really looks like, right? And things just get cross-contaminated, and we're seeing that population also overdose.
Yeah, and I do want to just mention when Ashley says cross-contamination, what folks, so everybody's on the same page there. There's a lot of conversation about, drug suppliers sprinkling different things into things, I've tested many drugs, and I just do not find that phenomena occurs. Instead, what often happens is, as we're saying, cross-contamination, that you may have some drugs on a table, other drugs come into contact with those. This very often happens when people are smoking drugs as well. So you might smoke meth out of a pipe, you might smoke fentanyl out of a pipe, then you put meth into it, and then people could overdose because there was previously fentanyl in there. So this is, again, a reason to make sure that we have a lot of provision of clean supplies for individuals who are using drugs as well.
I have a question in regards to your work with the law enforcement agencies and organizations. Do you find yourself seeing in your research, seeing that maybe law enforcement is conflicted with, it's kind of like, here we are, we're got to arrest and do all of this, and look for crime. And then we're also supporting, like a backup of some sort so that we don't see those overdoses. Do you find, them kind of, how do they walk that fine line?
Well, I am of the opinion that this war on drugs has done nothing to help out law enforcement. The behavioral health rates, the behavioral health concerns amongst law enforcement are equally bad. We have given them a task that is an entirely unsolvable task. And so it's not only increased, problems within that profession, but it's also really led to deteriorations between law enforcement and community. So I see this whole effort of having to take drugs from people as just contributing to a reason why we have distrust in law enforcement and why there are so many health and negative health situations going on in law enforcement. So I just do not think the war on drugs has fared well for them either. And that's one of the main, and so Jeremiah and I know each other through the SHIELD trainings, because that is one of the main messages that I have for law enforcement when I present this to them. And I'll also mention, you know, I presented this at a conference in Texas, and a guy down there actually, this is last year, stood up at the end of the presentation, threw his hands into his head, head into his hands and said, "Have you told other police about this?" And there are definitely police officers that I've told about this that now are trying to do interventions around it, that are trying to do work in this space. It does resonate, especially with more seasoned officers who recognize we're having no impact on taking these drugs all the time. And I think another thing, sorry to just ramble on here, but another thing to know is, you know, back when I got started in this, you needed muscle, you needed a gun, you know, you needed to sell heroin on a street corner. Nobody could just get a street corner easily. It is so easy to make fentanyl, to get fentanyl right now. Drugs are cheaper and more available than they ever have been. And so that's another thing that I think law enforcement are starting to see, like that term Ashley made of whack-a-mole. I hear that all the time, that it's a never-ending thing. So we really need to rethink how we're using law enforcement, in my personal opinion, to address the substance use.
Thank you.
Thank you so much. And thank you again, Brad and Ashley, for this amazing presentation. Please keep the questions coming. I'm sure they would be happy to answer them in the chat. But with the interest of time, we will move on to the next part of our session. Kito, could you please share the announcements from BVAL? The Center for Substance Use Training and Telementoring offers technical assistance for various substance use disorder needs and topics via a team of experts. To request technical assistance, please complete an online request form, and we'll be pleased to help you, and we will share this link on the chat. Next slide. To claim your CEU credit, you must complete the post-session survey in the chat or by the email sent after the session. Complete the post-session survey and select yes on the question, are you applying for CEU credit for today's ECHO session? We will send you the certificate of completion within 2 to 3 weeks of the session. Next slide, please. Cases are the core of an ECHO session, and we invite you to present any difficult case that you or your team have encountered. Case presentation is really easy. We give you an easy to fill form. You don't need to prepare any slides, and the presentation is only for 5 to 8 minutes. And the best part is you get real-time usable feedback and recommendations from the expert team and from this vibrant learning community. You can also send us an email with a brief description of the case, and our team can help prepare the case form. Please email us at cstat@utisca.edu. Next slide, please. And finally, join us for our next session on November 12th at 11 a.m. And with that, we will move on to our case for today. Kato, if you could please bring up the case slides, and Ashley, you can take it away from them once it's ready. Ashley, can you unmute yourself, please? Thank you.
Sorry. I'm going to run through this quick just for the sake of time. So with this first case, this is when I was a harm reduction program manager at a legacy syringe service program. I knew this individual personally since we were like 12. And so I knew all the backstory of what was going on with them as a veteran. And so they came in for supplies like they would for a harm reduction program. Somebody says, hey, you know, what do you need? How can we help you? And they were a participant, like I said, for a while since we knew each other. And when they left our parking lot, they were pulled over. There was no reason. I stood outside and watched it, and they were searched. They had no motor vehicle violations. They were given a paraphernalia ticket for supplies. and their supplies were taken. I went back out there and gave them new supplies. Next day. So this individual had a substance use disorder diagnosis, specifically, you know, after they were discharged for injuries that they obtained as a vet, and they had a previous possession sentence served. The next week, they came back to our office. They were really helping myself and others in the community who were really, really struggling with substance use. So they were bringing supplies, but also offering support. And when they came back the next week, their vehicle was impounded because they left my office. And when their vehicle was impounded, of course, they got in trouble because their work boots were in there, their work phone, you know, like all these things that happen when somebody is criminalized for being a substance user. I ended up paying it's like almost $1,000 to get their vehicle out of impound. During this time, they had a consistent supplier. They had the individual who was providing them a pretty consistent supply. And the supplier ensured that people had naloxone. They made sure that people weren't using alone. They were a wonderful seller. They cared so much about their community and distributed naloxone. They did fentanyl test strips. We didn't have much drug checking at that time. Sometimes we would send off. And so certain service program card is like a way to say, hey, you're part of a program. It's kind of an old thing that started years ago when needle exchanges or syringe service programs were started just so the police would leave individuals alone that obtained supplies. After he came back, he got pulled over down the road after leaving again for paraphernalia. And this was the last ticket that I have of his. His sister gave it to me. And he was jailed for 2 months for a paraphernalia charge because of being considered a repeat offender. These were all clean supplies. Okay, so these were paraphernalia with no drugs in them. He didn't have drugs on him at the time. When this happened, the supplier, who was such a great supplier, got busted. They were not related. He didn't snitch or anything like that. It just kind of co-occurred in the community. And so that supplier was gone. And so a lot of people were already overdosing. My friend who, you know, was released from jail, the jail did not provide him with buprenorphine or methadone. The jail did not provide any services to him. And so he had a complete tolerance break and was abstinent for 2 months. They did not treat his chronic pain. They did not treat, you know, any of the other situations that were going on. And when he came back, he stayed with a relative, and they were very harsh on him about being abstinent. And he was very, very sick still because, again, he was using fentanyl and it stays in the body fat for a longer period of time than heroin did. And so he was still feeling withdrawal, still very sick and in chronic pain. So he ended up, I don't even know where, but ended up getting a new supplier. That supplier was supposed to be very upfront with him of like, hey, this is stronger. They used, again, alone in a bathroom, and was discovered a few hours later dead from an overdose from that tolerance break a day after he was released from jail. And so this case kind of goes on of like, what happens when not even somebody has a tolerance break from jail, but also they're forced to get a new supplier because of drug bust. And what does that look like for individuals? If you want to go to the next slide, or I can stay on this case study just because of the time. Okay, there you go. Okay, so this one was actually really recently, this month. It happened in June. This individual left their methadone facility. They have been on methadone and in recovery for about 10 years. And when they were walking back to their encampment, because they are homeless, they had 2 needles on them in a package case, and it was not for themselves. It was actually because of the HIV and hepatitis C transmissions that were going on in the camp. So this was an individual in recovery of saying, hey, here's some supplies, please don't share, because we know our camp has an HIV outbreak that's not being addressed right now. And so after he left the clinic, when you get methadone, because they don't provide split dosing like many people need, sometimes you're a little bit sleepy. And so a police officer seen that as he was walking back from to the bus, and he was stopped, searched. There was no crime, no reason. And the officer said, well, you're going to the jail or the hospital. And they said, okay, well, I'll go to the hospital, of course, right? When they were at the hospital, they were given a paraphernalia ticket. So that, coercive options really didn't work. And the hospital actually gave him the naloxone. As he was awake, he walked into the hospital and they still gave him the naloxone. And if you're familiar with methadone, you can only get it once a day. You can't go back if you get Narcan. And so he was instantly in withdrawals, and they did not treat the withdrawals, they released them. With this situation, because this individual, with the multiple drug seizures that have been going on locally, the supply is just absolutely a mess. And every day it's something different at this point. They ended up having to use, so they weren't in severe withdrawals, especially because of the methadone, for how long it lasts. And luckily, we have a great relationship with this individual, had others making sure that they were okay, and only used a tiny amount just to stop from being so sick and going through the withdrawal process until we could get them into the methadone clinic the next day. This case was really interesting because over, the last 15 years, I've never successfully really been able to get a participant to have their paraphernalia charges dropped. It's an $800 fine, or $500 to $800, and also can be jail time. And most of the time, my individuals who receive paraphernalia tickets cannot afford an attorney, so they get a public defender. The public defender always demands that they plead guilty, even if they're part of a program that the state is funding, that the state is, helping us provide supplies to individuals, even within cities. It's always a forced plea deal. So in this case, we were like, no, this is just absurd. This person is leaving treatment. And so the public defender wanted them to plead guilty. And we just felt it was like a targeted intervention. So we ended up finding a pro bono attorney, which was great. And the court case, our attorney pushed back and realized that the police were really targeting this individual leaving methadone, leaving his clinic. And the prosecutor at first started pushing back. And then we were like, hey, this is an ADA violation for America, disability with an SUD. And then magically the case got dismissed. And so those are like my points of like, even with drug busts, like you're not making an impact besides maybe a negative one. And also just criminalizing health conditions are really making this much more worse than it needs to be.
Thank you, Ashley, for bringing these cases to us. I'm going to open up the floor for any questions or comments.
Ashley, can you explain to the participants what an SSP card is?
Yep, so it's a card. I probably have some somewhere. It's just a card that certain service programs, or what's called needle exchange programs, started to say, hey, I'm a participant of this program, please leave me alone. Like, please don't criminalize me for having health tools. And so it started around the whole country, and it's a way to keep things anonymous for individuals, but also helping keep track of, you know, what they're doing and if they need more supplies and things.
Thank you.
I have a question kind of for the audience, but it's apropos of these cases where there's an instance of law enforcement doing targeted enforcement at a treatment or SSP location. Is that something folks are seeing on the ground? I'm just curious about, I mean, if they locally, or if the word has gotten out locally at all that it's a bad place to conduct enforcement. There's an extensive evidence base on this, on how it reduces the value effect, the effectiveness of treatment facilities and harm reduction facilities, and I think people aren't going.
Well, I know that when I was in community corrections, and we had some judges that were very sensitive to substance use disorders and wanted to reinforce treatment rather than enforce, criminalization and revocations. I know that we were able to argue that if someone was arrested or targeted at a treatment agency, that we could throw that revocation out. And so, I mean, I think that if we have more and more, law enforcement or judges that are in support of harm reduction and treatment, and recognizing that we could, kind of eliminate some of those targeted law enforcement arrests.
No, in our SHIELD trainings, this is something we specifically talk about, is that once it's established how SSPs and program treatment and peer coaches and other resources are effective and useful for public safety, that if you have come to agree with that, then you should not conduct your enforcement there. I mean, it might seem like it's sort of a shooting fish in the barrel kind of thing, but it backfires. It's not a good idea. Sorry for the use. I was trying to think about a good metaphor would be there, but it's like a target-rich environment if you're just trying to get some misdemeanors arrests on, or some felonies. So there's a lot of vacuuming noise in the background. It might be making it loud here, so I'm gonna mute again.
I'll just add, we actually have a study, and maybe I could come back in a year and talk about it, where we're looking at people who are under criminal legal supervision and how that is a barrier to accessing harm reduction services. And so if you've been arrested and you've gotten out of jail, you might be a little bit nervous to go to a SSP and get syringes, but if you're on probation, then you get really nervous. I mean, people on probation, could you imagine like taking your drugs to get checked at some place, even though that could save a bunch of people's lives? They're just too scared to do it. And then one other thing, Cynthia, I would say is, in the court space, I do a lot of work with judges. And a couple of years ago, I had judges say, like, how can we start doing more harm reduction? But there has to be a realization in some criminal legal practitioners' minds that they can't. We can't all do this. And if your job is to sit on a bench and put down, sentences and decisions, it can be very difficult for a judge to say, hey, next time you make sure you take a test shot and use a trusted supplier. Judges can't say that. So this is the beauty, the importance of peers, persons of lived experience, harm reductionists. And if judges really want to do that work, they need to say, go talk to that group, go talk to that SSP, go talk to this peer, this navigator, whomever. It can't always be them doing it. And then what ends up happening is they get frustrated because they can't do it. And then they say, well, let's focus on this recovery thing because I have my arms around that,
That's a great point, Brad. Thank you for bringing that up. Any other questions or comments or any similar experiences that you've had here working locally?
I had a funny quick anecdote for you. I was once walking by a methadone clinic, and there was a tent, one of those like event tents, sort of pop-up tents right in front of it, and there were officers handing out free clothes, toiletries. Like, it was straight up helpful thing. But they also were trying to get PR credit for it. So they had a photographer walking around, and the tent was a recruitment for the police tent. So I went up to talk to them, and I was like, so what's going on here? And then I talked them through this thing. Then they finally it kind of clinked, and they go, oh yeah, I was wondering why so few people are showing up today.
Yeah, the first SSP that opened up in Indiana was right across the street from a syringe service program, and they couldn't figure out why people wouldn't come. Hey, I will say, since I have so many wonderful folks that are on the ground doing this work, there is one message I always like to get out at these things, and that is beware and avoid high-dose naloxone. It is bad. They are coming to you. They are trying to sell it to you. You should avoid it. It is not good for your clients, your community at all. This is Opvi, Caloxidone. I don't know the other names of them right now. You want to get the, and also I would say, and I know it's hard in Texas, a lot of people want injectable naloxone. A lot of people who use drugs prefer that. So make sure you're not just stocking vending machines with nasal. Jose, sorry. Saw you hop off mute there, Jose.
Okay. Yeah.
go ahead.
Key message.
Yeah. So thank you so much. I know this has been a wonderful discussion. In the interest of time, I will request Jeremiah to please summarize today's discussion.
Cool. I will do my best. I mean, first of all, thanks to Brad and to Ashley for coming and joining us today and talking about these key topics. And it's obviously distressing when many of these it's not rocket science. The feds already knew this was gonna, the shutting down prescription was going to lead to more use of street drugs, and it was going to lead to more overdose. That know when in enforcement, when local arrests are going to disrupt the drug supply, and people are going to die, and yet we don't do enough on that. Where there's extensive research on how conducting enforcement activities at harm reduction and drug treatment facilities leads to less use of those facilities, as well as to the harms that come to the direct person who was arrested, and how things go downstream, and the lack of treatment options within jails and prisons, et cetera. So this is hitting on a bunch of these key points, but these are things that have to get said over and over again, and pointing out how this knowledge is kind of sort of known and well recognized is key. And spreading this word out, that making arrests of drug sellers is not a magical way to make drugs go away. When like Brad said, you're talking about 5% of people of drug sellers are even known about, and then there's this kind of these efforts to help go awry, like with this push to have high dose naloxone, which is putting people into precipitated withdrawal, and causing even fewer people to call 911 if they want to have wanted to get help seeking that way. It seems like we all just kind of can't help but shoot ourselves in the foot. So I guess we have to keep talking and keep putting this knowledge out there and sharing. So thanks to you all, and I hope you all have a great Thanksgiving, and we'll see you again in December.
Thank you so much, Jeremiah. And thank you all again for joining today's ECHO session. As a reminder to earn continuing education credits, please complete the post-session survey using the link in the chat. If you would like to present a case, please email the BVAL Texas team. We look forward to seeing you at our next session on Thursday, December 12th at 11 a.m. Central, Thank you all. Have a wonderful rest of your day and happy Thanksgiving. Thank you. Bye-bye.